Targeted therapies, as far as routine clinical practice, is something that we're still trying to implement and better understand. As of right now, the biggest study was a SHINE study, which was a Bruton combined with Bendamustine and Rituximab. That was a positive study, albeit with some caveats that, with the increased toxicity that we saw with the combination, does call into question, what role that'll have moving forward potentially. There are several sister studies to that study that are coming out. There's an ECHO study that is looking at acalabrutinib plus Bendamustine and Rituximab. The one difference between that study and what we saw in the SHINE study is that study does allow crossover for those who progress on the Bendamustine and Rituximab arm alone. Additionally, zanubrutinib is another BTK inhibitor which is being looked at in a frontline setting in a study against Bendamustine and Rituximab alone without any chemoimmunotherapy. And there are some studies actually coming out of Europe which are also adding ibrutinib to regimens that we typically use with aggressive patients with mantle cell lymphoma, young and aggressive patients, should I say, prior to going to auto transplantation. So I think in the next couple of years we'll have a better idea whether these agents will sort of solidify themselves in a frontline setting. As an aside, since we are at SOHO, the MD Anderson group did look at a study with a one-year lead-in with ibrutinib and Rituximab prior to treating patients with hyper-CVAD. Based on their response to that one-year lead-in, they got a varying number of hyper-CVAD chemotherapy cycles. So at least within the U.S., that sort of regimen has an NCCN designation that it can be utilized if you want to reduce the typical number of doses that patients want to receive as hyper-CVAD. So.